Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh.
You feel weird when you go in there. Did you turn into a Ninja Turtle?
Immediately.
Think about how much more work you're getting done now that you have a third arm.
Abnormality, thank you.
I feel like your hair raises.
Bad things will happen. So, I had a patient, Dakshita Vidanagamage. That's a word.
That's a good word. Go team.
Go team. Welcome to the Fresh RN podcast. I am Katie Kleber.
Hey guys, my name's Elizabeth Mills.
Thank you guys for joining us. Today, we're talking about diagnostics for new nurses. So we're going to talk about some basic differentiations between some diagnostic studies that are very common, and you will most likely see, maybe even day one, we're going to talk about x-rays, CTs, MRIs, angio, and nuke med. Yeah. Very common.
And we're going to kind of keep it short and concise. Not to overbore you.
Yeah, because
this is kind of a boring one. Yeah. We might throw some funny stories in there somewhere.
So let's talk X-ray. It's one of the most common diagnostic studies. We use radiation to view dense objects in the body, like some bones, organs, or tumors, and we can normally detect fractures, dislocations, and some tumors or even infection. Chest X-rays, abdominal X-rays, they can detect things like air, fluid, or edema. Sometimes they'll say they want a 2-view or 1-view, give me a portable chest X-ray, 2-view, or whatever.
Anterior and lateral or whatever.
Yeah, they'll say, like, I want a chest X-ray, but what kind of view do they want? And some are portable where they come to the room and do it, which in the ICU I see more frequently. And then if you're on the floor, typically they can go to the radiology department and get the X-ray. Keep in mind...
It's actually safer that way.
Yeah.
Best used for capturing hand puppets. I think that's my preference. Right.
Have you ever seen the radiology selfie?
Mm-hmm.
The radiologist selfie. It's two people like taking in an X-ray. Have you seen it?
No.
I'll have to put it on the show notes so people can see it. It's kind of funny. But keep in mind, X-ray is radiation. So if you're doing it up in the ICU, there's people are being exposed to radiation within a certain amount of distance of that scan. So it is best if it's done downstairs. And I think you get a better view anyway.
Yeah.
But there are a lot of situations where the patient can't travel just for a simple X-ray. So special consideration should definitely be taken if the patient is pregnant. And nurses who are pregnant should keep a really safe distance from portable X-ray machines. So that was something when I was pregnant I had to run away from, because our patients got X-rays after they got an intubation, a breathing tube to make sure it was in the right place, a feeding tube, a central line. There's lots of different reasons patients get X-rays. I think I've X-rayed out. Are we good on X-rays?
Yeah.
Should we move on?
Yeah, let's move on to the CT.
All right. I'll chat CTs, and then Elizabeth will go a little bit more into MRIs. So CT scans is a computed tomography that uses higher levels of radiation to obtain more high-quality images of the body. So we in neuro ICU do brain CTs
all the time.
And a radiologist told me, and I don't have the reference to this, so please don't quote me, but a physician told me this, that one CT of the brain, the amount of radiation utilized to get a brain CT is equivalent to 200 chest X-rays.
Oh my goodness.
Lots of radiation. So it's kind of one of those things that you don't want to just do. You want to have a good reason for it, because it's a legit amount of radiation that the patient is exposed to. So, but you know what? A lot of times it's very necessary.
Right.
And it's a wonderful thing to be able to see things. So CT allows images from various viewpoints. They take as little as 30 seconds, but can take up to several minutes. But they're wonderful, especially if you've got patients where you need to see something internally very well, but they're not going to lay flat for a long time.
Yeah, they give a better picture of tissue and organs and bones. But the patient runs through a small little tube, and it takes, multiple slices of whatever organ they're looking at. So you can find what the problem is.
Yeah, so higher levels of radiation are used. So you got to make sure the patient, so pregnant women should not have these done at all unless it's like like absolutely life or death situation. And, medical staff in the room
should not be in the room.
And sometimes, especially if you have a ventilated patient, ideally a ventilated patient getting a CT scan should be on a portable ventilator.
So that
the the respiratory therapist isn't in the room bagging the patient getting exposed to radiation unnecessarily. So that's really, really important aspect of this because of the level of radiation. If they are present and in the room, they have to wear lead barriers. And something with CT scans, patients can get something called IV contrast. Yeah. It's something administered through the IV to enable to kind of see vessels and things better. It's basically dye.
And sometimes they get contrast orally too.
Oh yeah, they can get it orally.
To evaluate usually stomach, intestines, get a good picture of what's going on.
Yeah, barium. So they mix it with some fruity drink and it. But it's very necessary. But if the patient is getting contrast, we got to make sure they've had a recent creatinine level because the dye is metabolized through the kidneys and it can be dangerous for patients who have renal issues.
Yeah.
Big deal. One time I had a patient that had a CT, I can't remember what it was, but they were a diabetic and they were on metformin. And metformin, when you have to give... I believe you give a medication before the CT with contrast, and then you hold a couple doses of metformin, and then they get IV fluids, I think.
To flush the kidneys out.
To flush it out. So it's important to make sure that kind of, you do not overlook that, because that can be something that is easily overlooked if you're a busy nurse and, okay, my patient's got a CT, okay, good, I don't need to worry about it. And if you don't think to look at the creatinine, the doctor doesn't think to look at the creatinine, and the CT tech doesn't think to look at the creatinine, you can put someone into kidney failure.
Yeah. And it can be very dangerous, the metformin glucophage, in contrast. And I'm not exactly sure what the physiology behind it is, but it can be toxic to the kidneys together.
Absolutely. So those are important things to remember with CTs. I remember when I first started in the neuro ICU, again, Elizabeth was my preceptor, and a lot of our patients would get CTs of the brain. And normally a CT is done without contrast in general. And if it's being done with contrast, they will specify that. So, she would say, okay, this patient's going to get a CT brain without. What?
What does that mean?
What the heck does that mean, Preceptor Elizabeth? So that would mean that they're getting a CT scan of their brain without contrast. If they said, get a CT brain without, that means I want 2 scans done. I want 1 scan done without contrast, and then I want the radiology tech to insert contrast into their IV and take another scan.
And a lot of times they could be looking at the blood vessels when they do contrast. Or
yes.
You can have a CT angiography, and we're going to talk a little bit about angiography in a little bit. But anyway.
I think that kind of
don't, if you're pregnant or could be pregnant, you don't really need one unless it's life or death. Pregnant nurses should not go in a CT room while the X-ray. Nobody should go into the CT
while it's
room while it's going on. But you especially can't go in there if you're a prego.
So you want to talk about MRIs?
Yeah.
And what the difference is too.
MRIs are it stands for magnetic resonance imaging. MRIs do not use radiation to look at tissues and organs in the body. They use a very powerful magnet. They give great imaging studies. High resolution, so you get good pictures of organs, bones, soft tissue. You can look at blood vessels with MRIs. I think they do. They do MRIs of the heart, stuff like that. And the problem is I've had families say, well, why didn't we just do an MRI rather than a CT? MRIs, they take longer.
Much longer.
Anywhere from 30, 45 minutes to as long as several hours, especially if you're getting an MRI of the spine. And you have to lay completely still in a very long tube, and the machine is very loud.
Very loud.
So it takes a long time to actually do the test itself. And then if you're moving around, you're not going to get good pictures. patients who need this kind of study, a lot of times will get some sedation, or sometimes they even have to have anesthesia to lay perfectly still, because if you're claustrophobic at all, you won't be able to tolerate it. And the CT scans give us that's a quicker test, and so if something major is going on, a CT scan will typically pick up on it. But the thing about an MRI is it's a magnet. It's a very powerful magnet.
A big old magnet.
So patients who have a pacemaker or metal or
shrapnel
in their body,
bullets,
they usually are ruled out for an MRI, especially a pacemaker. And the reason is it'll kill them if they go in that machine.
Yeah, or if it doesn't kill them, it can really, it can move bullets in people.
Yeah.
If someone has a bullet that they've just left in, I had that once where I had a patient that had a bullet in his, I don't remember where it was. I don't know, but it wasn't, they weren't going to take it out. So we couldn't do an MRI. One time I had a patient that had an ankle bracelet on. That couldn't go on the MRI machine. I mean, actually, on the show notes.
Oh my goodness.
Yeah,
like a house arrest.
Yeah.
Oh.
Yeah. I was like, well, this is an interesting situation. Like, he for real needed the MRI. They had already done a CT. They needed a more detailed picture, and they wanted an MRI with contrast.
MRIs, the powerful magnet, or the potency of the magnet, is measured with Tesla. I don't know, it's something over my head, but the higher the number of Tesla, the more powerful the magnet. So know your hospital's MRI machines and their measurement of Tesla or whatever, because I think that can determine whether or not you can even be present near the MRI room or go in the MRI room as a medical professional.
It was funny is I've taken, as a critical care nurse, we have to go with our patients to MRI,
right,
and to CT, and you get them from the bed to the scanner, and I go in the room, and I've had bobby pins pulled out of my hair.
Yeah, earrings will come out.
Earrings fly out of your ears, or I've had
don't take your cell phone or credit cards in there.
Oh, you better not do that. You're gonna screw up your stuff. And I had my badge on, and it got sucked to the scanner.
Oh yeah,
or to the So I had to like go in and retrieve it, and then actually. One time I had a patient, it wasn't my patient, it was another patient, and they went down to MRI, and the patient was on a ventilator, and it was going to be a really long scan, and you can only get the ventilator so close to the MRI.
Yeah, they have to have special MRI compatible ventilators.
More like an alien encounter than
totally
nursing.
Is. You feel weird when you go in there. It's not, I feel like, I'm like, is this what getting ready to be struck by lightning feels like? Because I feel like your hair raises. It's the positive and negative ions in your body are like, what?
WTF.
The metal. It's like, I don't know.
But so this nurse and her patient were gone for like hours and hours and hours. It was going to be one of those, an MRI that was only probably going to take an hour. Come to find out, someone had accidentally pushed the ventilator slightly too close. And the ventilator got stuck to the MRI machine.
And it will fly across the room.
And oxygen tanks, wing! And you have to...
It can kill you.
If you're in the way. So really...
Bad things will happen.
And actually, Elizabeth has this in caps in our notes. Bad things will happen.
So...
Twice.
Yeah, multiple. Yeah. Because... and the MRI technicians down there are very knowledgeable in the machines, and just make sure you listen to them.
Oh, yes. Yes.
And they're going to screen that patient before the test is done. So if that patient is not with it, you need to know or have a healthcare representative or family member that can be reached to help answer those questions, because you don't want a patient, and if they're not sure, like if a patient said, well, something, I might have this metal thing in here or not, but I'm not too sure, they may do like x-rays before they do the MRI to make sure whatever is in there is compatible. And they're familiar with, some people like the stents. There's certain stents, coronary stents now that are I don't know, have some issue or potential issue with MRI. So they may not be able to go into one particular MRI machine. There's also open MRIs now, which
that brings up something that I wanted to bring.
I think someone told me that they are being they're changing pacer composition. I don't know, so that pacers are going to be compliant with MRIs or something like that. I don't know what the whole deal is. But anyway, what was your story?
If your patient is having an MRI and they're morbidly obese, you have to look and see if they'll fit in the scanner.
Right.
And I'm legit. There is an open MRI that I have had to take patients across the street, not on the actual street, but in the walkway over the street to go to the open MRI because they will not physically fit into ours and we need to scan that bad.
Yeah.
So, and then sometimes they don't actually, I have a friend that works in downtown Chicago and they have a regular at a hospital. I'm not going to say the name, but they have their regular MRI, the open MRI. And actually they've had to actually go to the Lincoln Park Zoo to use that MRI before for patients that are 600-700 pounds but need an MRI.
Someone told me that once too. I just talked to someone about they had to go to the MRI machine at SeaWorld.
Yeah.
They had a patient that needed an MRI.
Yeah, so that's the thing is if you have, sometimes it depends. Like if you're doing an MRI of the brain, their whole body doesn't need to go in there. But
their whole body does go in there.
Well, not all the way. If their hips are huge or something like that. But I've had MRI technicians come up to the unit and measure patients. They'll look at their weight and say, actually, this isn't going to work. We got to figure out what to do. So that's something to keep in mind with MRIs. They'll have the table itself will have a weight limit. And then there's also the circumference,
the girth
of. That's a word.
That's a good word.
Girth. Good word. Good usage.
Yay. Okay. So MRI.
Let's move on to actual angiography that's done in interventional radiology.
All right, guys. Angiography involves visualizing certain vessels in the body, either with the use of a CT scan or special X-ray called
fluoroscopy.
Usually an angiogram in interventional radiology, or called IR, is performed by a radiologist at the bedside. It involves direct visualization of vessels by a small catheter placed in the groin that's injected with contrast dye. Typically, patients will have this particular study done in interventional radiology to diagnose or possibly treat any abnormality, thank you, that is seen with the vessel, like stenting a narrow carotid artery, placing a filter in the inferior vena cava to prevent passage of blood clots to the lungs. That's pretty common. Considerations for these studies including keeping the patient NPO for at least 6 hours prior to the study, and often patients are sedated because they could aspirate, and that could be a risk. Patients also have to lay flat, have the head of bed flat for hours after the study is performed to allow for appropriate hemostasis to be achieved at the puncture site. So the patients will need close monitoring of vitals and puncture site post-procedure, as well as the extremity distal to where the puncture site was. So pedal pulses, essentially, those kinds of things.
Right.
Really important to know.
So they'll get conscious sedation for the procedure, so they can lay still, because literally, you have a catheter injected into the artery. You don't want them to move around, and then the artery gets blown. And so we see this in a neuro ICU. We see these a lot because they do cerebral arteriograms, oftentimes in with our neuro patients. And then but they do arteriograms elsewhere. If they're looking at GI bleeds, they may look at the blood vessels in the abdomen to see where potentially the bleeding is coming from. But they need to be one NPO for at least 6 hours, because they're going to lay flat. They're going to get conscious sedation. You don't want them vomiting during the procedure and aspirating. That's a whole nother issue. And then they need, the close monitoring post-procedure to make sure there's no signs and symptoms of internal bleeding or clotting off of the artery that they accessed. I've had that happen before, where the femoral artery clotted off. We lost pulses to the feet, and we're in big trouble.
Yeah, and you can have, what is that? Retroperitoneal
Bleeds.
So
If the artery's punctured or...
Yeah, and then you can have lower back pain, or you can see a big hematoma.
Right.
I've seen a couple patients with that, I think. And then also you can have it where the site doesn't stop bleeding.
Right.
Maybe they get
That seems
hemostasis.
to be,
And then it starts
Rebleeds.
bleeding again. So then you do something like you put a fem stop or you put something on it, but you can only leave that on for so long because then you're cutting off blood flow to the foot. So, there's a lot of considerations with the angio.
That's why patients have to lay flat for that period of time, and they really need to keep whatever extremity they punctured, they should keep that extremity still. So if they went through the right groin, they need to keep the right leg still. That's also another cardiac catheterization. That's essentially what a heart cath is. It's an angio of the coronary blood vessels. So those same considerations are used when a patient has had is going to have a cardiac cath and has had a cardiac cath. That's what you do to monitor them.
If it's a femoral approach.
There's also the radial.
The radial, right. Which is
that's new.
It's
newer.
It's a newer thing, but it's pretty cool because they can go through the radial artery and go to the heart, and then the patient doesn't have to lay flat. They have a wristband that you slowly take air out of until you achieve hemostasis. It's awesome as a bedside nurse because it's a lot easier to do, and then patients like it more because they don't have to lay flat. And I'm not sure about outcomes, but I would think they have better outcomes.
I think they do. That's why they do them more.
Yeah, so those are pretty cool. So that's another thing to consider too.
So now let's talk a little bit about nuclear medicine. Nuclear medicine, obviously, it sounds weird or crazy, but
nuke med.
What that involves is some kind of radioactive isotope that's either injected through an IV or ingested through the mouth or whatever, and that helps to visualize an organ function. Nuclear med scans can include PET scans, VQ scans. PET scan is usually used to look at bones throughout the body to diagnose like metastatic cancer. VQ scan is another way to diagnose or to see if a patient has a pulmonary embolism. Nuclear stress tests involve the heart, looking to see if possibly there's any cardiac ischemia.
And you do those if a patient is not able to do this cardiac stress test where they're actually on the treadmill.
Right, if they can't get up and walk around or get up and run or whatever.
Yeah, what is that? What's the other word for that? Chemical stress test or something like that?
There's chemical stress tests, but then there's the nuclear. There is a nuclear stress test.
Okay,
yeah.
See, I don't know.
They can also do nuclear med studies to look at gallbladder disease, GI disorders such as a GI bleed. It's called a bleeding scan, which I've seen or dealt with a lot. But you have a nuclear med technologist who will come. These tests often take a long time too. So if you're especially in an ICU and you have to travel with the patient, you need to let your lead or charge nurse know that say, hey, I've got this nuclear med scan ordered, because typically the technologist will come, inject the isotope. They have to wait like 30 minutes. Then they go down to nuclear med. They look at the organ under their scan. You have to stay there for a while, come back up. Sometimes you have to go back down again. So it can be several hours of testing that you do. So if they're on the floor and they don't need monitoring, your patient's going to be gone probably for a long period of time. Mm-hmm. But what happens is the technologist will inject the isotope in most cases. I know Katie has a story to share in a second. But once again, if you are a nurse who is pregnant, you should not probably take care of that patient that day, because you don't want to be anywhere near radioactive material. Anyway, you want to share your story?
So I had a patient, and I honestly don't remember I had to give him a small amount of nuke med stuff, and I had never done it before. I was a new nurse, and the patient had a PEG tube, and for those of you, a percutaneous, what does PEG stand for? Percutaneous E.
Percutaneous endoscopic gastrostomy.
Thank you. Good Lord.
I like to spell it.
Oh, do you? I like to spell tracheostomy.
I like to spell endoscopic gastroduodenoscopy, EGD.
Oh, nice. I'm trying to think of a better
Or
one.
an ERCP, which I don't even remember what that stands for, but it's like a
I couldn't begin to even think about spelling any of those.
Any of the things.
Yeah.
What is ERCP? I'll think about it.
I'll tell my story. You start thinking of ERCP. And there's probably 40 people listening to this that are like, I know exactly what that is. I'm going to tweet to you right now what the ERCP is. So please do. But I had a patient and they had a PEG tube. And I had to push this nuke med stuff in. And it was a small amount. And I'd never done it before, didn't know anything about it. And so on a PEG tube, you know, I had a Lopez valve on it, which is, I love Lopez valves because, you know, it takes a step out, you know, it's like a valve as opposed to like taking things off and putting them back on. They're wonderful when you have a PEG tube. But I had it flipped the wrong way. So I sprayed myself and him with some nuke med stuff.
Did you turn into a Ninja Turtle?
Immediately.
Did you immediately turn off the lights and see if you glowed?
You're glowing.
And then I immediately had a craving for pizza. No, so you know, not.
And you got some nunchucks.
And then Scar picked me up from work, and no.
Oh dear.
Oh, it's not Scar. I said Scar. Splinter. Excuse me.
Splinter's the rat.
Yeah.
Yeah, that's right.
Come on.
Shredder's the bad guy.
Shredder's the bad guy, and then Scar is from The Lion King.
That's right.
Way off.
Way off, guys. So basically, I've been sprayed with tube feeding. I don't even know how many times because I forget to flip that thing.
Just think about how much more work you're getting done now that you have a third arm.
That would be fantastic.
That would be fantastic. So yeah, basically when you're giving that medication stuff, and hopefully that's only happened to me once where I ever even had to have anything to do with it. So make sure you're turning your valves the way you need to. What's ERCP?
And so for those of you who need to get a consent for an ERCP and you're not allowed to abbreviate, an ERCP is an endoscopic retrograde cholangiopancreatography.
Dang girl.
Naturally.
So yeah, keep in mind when you have to get those consents, you can't.
Oh yeah, you can't
abbreviate. So you got to know how to spell all that stuff.
Yes,
it's so much fun knowing how to spell that stuff.
One of my best friends in school was Dakshita Vedanagamage, and I can spell it.
That's awesome.
What? Maybe I'll put it in the show notes. I don't know.
Dakshita
Vedanagamage, and he was one of my good friends, and I enjoyed hanging out with him.
Well, that wraps up our diagnostic. Thanks for listening to us nurse geeks talk about
ERCP and Ninja Turtles.
Stuff that makes us happy.
Yes. All right. So thank you guys so much for listening. Check out freshrn.com/podcast. Maybe I'll put a picture of a ventilator that got stuck to an MRI machine.
Oh, someone just sent me one the other day. Someone posted it on
Send it
Facebook.
to me and I will go ahead and put it on our show notes. I know that I've seen one of a ventilator and I've seen one of a entire hospital bed.
Yeah, that's what I saw, the hospital bed.
Somebody was having a bad day. All right, guys. I hope this helps you guys. Check out freshrn.com for show notes, gear, books, shenanigans, all that good stuff. Thank you guys so much for listening and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you